So this compound is a radio enhancer. It's based on it's an aphthium oxide nanoparticle that will react with the X-rays and deliver more electrons than what usually happens when electrons encounter a molecule of water. And it will increase by 9-fold the energy delivered at the level of the cancer cell. So it's really small particles. Several particles enter inside the cancer cell, so it's really precise the way it's delivered. And the dose increase is really focused in the tumor with no side effect outside of the tumor. The cancer in which it's the most advanced is sarcoma. So in sarcoma, it's injected by the radiologist under CT scan, soft tissue sarcoma. And then patient undergo radiation with this enhancer and then surgery. So they're the most advanced. For head and neck cancers, it's the phase 1 has just been completed. So it's about the same thing, but it's not injected by the radiologist. It's injected by the surgeons during a panendoscopy. This is the name we give to the exam we do to the patient for the diagnosis. So it's under general anesthesia. And so we do the same process again, just really evaluate where the tumor is precisely, and then inject inside the tumor, avoiding the juxtatumor tissue. Yes, exactly. It's the topic of the presentation here. So we reported the primary endpoints that were safety and see if we had any dose-limiting toxicities. So actually we had no dose-limiting toxicities. So really to understand for the dose, it's the concentration of the product itself is always the same. What changes in the dose escalation design is the volume we inject, and the volume is calculated in percentage of the baseline tumor. So it's adapted for each patient. And 5, 10, 15, and 22% of the baseline tumor volume were used. And it included 19 patients at the end. And so we had no severe adverse events, no grade 3, no grade 4. Just 4 grade 1 and 2, 2 minor bleedings, 1 asthenia, and 1 grade 2 oral pain. And the other ones were grade 1. It is. So we also had secondary endpoints in the phase 1 for efficacy. We had quite a lot of complete responses, mainly at dose 15%. The dose 22%, the patients are more recent, so we also have some complete responses, but we cannot say if they are maintained over time because it's more recent. However, I would say that maybe, it's 2/3 of the patients that have an oropharyngeal tumor, and among them, a quite an important fraction are HPV positive, so they are known to be radiosensitive. So we cannot say so far, and it's not the purpose of a phase 1, of course, if really it's the compound that helped. But still, it's encouraging to have so many complete responses and prolonged over time. Yeah, so the phase 2 will start in January. So it will include more centers. So far, we're only 4 centers, and it will include several countries. So now we have France and Spain, and we'll have more countries over Europe participating. Because really, we have to understand that it's a compound. For now, it's designed for a niche of patients who are elderly and eligible for radiotherapy alone as standard of care. So most of oral cavity tumors, they undergo surgery first. So it has to be patients that cannot undergo surgery because either very important comorbidities or because of the way the tumor is. It's more frequent for the oropharyngeal tumors, but still it's a very precise indication. It's not a treatment for anyone so far. The development now is for really targeted populations, so elderly patients with head and neck cancers eligible for radiotherapy alone as a standard of care. So it's not for before or after surgeries. Patients with advanced tumor that cannot benefit from surgery. We want in this population to enhance the effect of the radiotherapy. So cisplatin cannot be used after the age of 70 or unless on very fit patients. And cetuximab also has been proposed, but the results are not so good. It's not as good as the cisplatin, and it's even more controversial in the elderly patients. So at the end, we do not have many options to enhance the effect of radiotherapy alone, and we know that this treatment has it has good outcomes, even more in HPV positive or oropharyngeal tumors, but it's not perfect, so we really need to improve the treatment and to try to reach the efficacy of combined chemoradiation. That is the treatment that we give to younger patients. The other things that we can say is that you were asking for other cancers, so we talked about sarcoma. It's also being developed in other types of cancers, liver cancer, prostate cancer, rectal cancer. So, and each time it's adapted to the organ. So, for example, the prostate, it's the whole organ that we inject, so it's really custom to each cancer type. And the other thing is that since it's a treatment based on physics, it's quite easy to add some other treatments, systemic treatments, such as chemo or immunotherapy, without increasing the toxicities. So it's much more easy to combine this physical nanoparticle with immunotherapy than two immunotherapies together.